So what I would like to do today is I would like to speak a little bit about the evolution in the management of stage 1 and 2 disease. So that will encompass um, stage 1 disease and then stage 2, meaning only retroperitoneal lymph node involvement. And we will talk a little bit about chemotherapy, not too much. I won't go into the controversies there, but we will talk a little bit about controversies of stage 2A and then post-chemotherapy residual mass management. And I have actually the opportunity to show you our own results because we worked those up over the last 2 or 3 years and published them. And as you will see, we are doing actually quite well. So these are the learning objectives, which you probably have seen. I have no disclosures for this topic. So when we look at the last 40 years in testicular cancer, that picture just illustrates you how much progress we have made. And we have gone from a malignancy which had a cure rate around 10% in 1970 across all stages to a malignancy which now has a cure rate of around 90 to 95% across all stages in experienced centers. And that really was made possible by this man. And some of you may not know him. This is Barnett Rosenberg. And Barnett Rosenberg was the first one to actually find cisplatin and to realize that this could be an important chemotherapy drug. Interestingly enough, the development of cisplatin was almost stopped because of the extreme toxicity of this drug when they started to do phase 1 studies. But eventually, due to its activity in testicular cancer, it made its way into the armamentarium we have. And it still today represents one of the most important drugs we have in our portfolio. The pivotal study, and this is one of the rare occasions in oncology where a phase 2 study changed the landscape of a disease. This is the pivotal study which led to the introduction of combination chemotherapy in testicular cancer. And the study was carried out at Indiana University by these two gentlemen, Larry Einhorn, who still is the head of department, and John Donahue, the urologic surgeon at that time. I would say two visionaries who have really developed that field over the last 30 years and can be thanked for a lot of the progresses we have made in that period of time. Today, the landscape of testicular cancer has really changed, and we are rapidly moving towards early stages. We overall see an increase in stage 1 disease. Metastatic patients are increasingly rare, and within the group of stage 1 patients, we see an increase in stage 1 seminoma. That is a quite interesting development, and we don't know why. We know that overall the incidence of testicular cancer has about quadrupled over the last 40 years. Again, a development which we have not, which we don't know exactly why that happens. So when we talk about clinical stage 1 non-seminoma, I think we have to recognize that there are a number of overriding principles which guide our treatment today. As I pointed out, about 60 to 65% of cases present as clinical stage 1 with no clinical signs of metastasis. And of those patients, 50 to 85% are cured by orchiectomy alone. So by a simple surgical procedure, we can cure 50 to 85% of patients. We know that in non-seminoma, the recurrences usually happen very quickly, and most of the recurrences happen within 2 years after orchiectomy. And what differentiates testicular cancer from almost all other malignancies we treat is that chemotherapy, classic chemotherapy, provides a safety net which we can rely on. Almost all patients are reliably cured with chemotherapy when they relapse from a stage 1 on surveillance. So that has led to a change in how we perceive testicular cancer, and in particular stage 1. And quality of life is now the most important driver of treatment decisions in early stages of this disease. So clinical stage 1 non-seminoma requires to have a clean CT scan of the abdomen and pelvis and a clean chest X-ray and or CT chest, as well as normalized tumor markers after orchiectomy. And I would encourage all of you to perform that minimal staging when you have a patient with a suspected testicular cancer. And then the patient has three options. This is the luxury of having options. We have to talk to our patients what to do next. Patients can undergo a primary retroperitoneal lymph node dissection, adjuvant chemotherapy with what still is the standard 2 cycles of BEP, or patients can go on active surveillance. Whatever we do, 99 to 100% of these patients should be cured. If you don't have a cure rate like that in your institution, then you have to do some serious investigation. Luckily, in stage 1 non-seminoma, we do have risk factors which will at least predict in a moderate way whether patients are at risk for relapse or not. Ideally, we would have a marker who tells us this patient is at risk and this patient is not, in order to allow us to tailor our adjuvant therapy appropriately. In stage 1 non-seminoma, clinically we use lymphovascular invasion, and that has been there for the last 20 years. And unfortunately, nothing has changed in that period of time. In patients who have lymphovascular invasion, the risk of recurrence is about 50%. If lymphovascular invasion is absent, the risk is about 15%. To diagnose lymphovascular invasion requires an expert pathologist. There have been reports that there is up to a 30% difference in what pathologists call lymphovascular invasion between experienced centers and community pathology practices. So this is something we always look at, and then have a better way to discuss with the patient his prognosis and risk of recurrence. So when we talk about treatment options, ideally, the ideal adjuvant treatment option should be easily delivered. It should avoid any therapy for those who are cured by orchiectomy alone, and it should minimize the number of patients who require dual therapy, so either radiation plus surgery or chemotherapy plus surgery to achieve cure. The treatment modality which has been around the longest is certainly RPLND for stage 1 disease. That has been around since the 60s and the 70s. And there are a couple of distinct disadvantages to that treatment method. Number one, we are really unable to safely identify patients who really need it. The number of patients who have normal-looking CT scans but still disease is fairly high. A high-quality nerve-sparing RPLND can only be delivered by specialized surgeons and experienced centers, and it has been clearly shown in a phase 3 study from Germany published in 2008 that community RPLNDs are associated with not only a higher morbidity but also with a higher risk of recurrence. So an RPLND represents an overtreatment and unnecessary surgery in 50 to 80% of patients, depending on the risk profile, has an acute morbidity of about 5 to 10%, and can have some quite significant risks for the patient. For me, most importantly, it does not eliminate the risk of relapse outside the retroperitoneum, which is still between 5 and 10%, depending on the series you look at. Follow-up and compliance is still necessary. And I think really the most important point, at least for North America, is that most patients will never make it into a center of excellence where we can offer this type of operation with an extremely low morbidity and risk of recurrence. Adjuvant chemotherapy has been tested as well and has been shown to be very effective with 2 cycles of BEP. As you can see here, the number of relapses for stage 1 non-seminoma is exceedingly low. However, it has the same disadvantages of any treatment option in active treatment option in this setting. It exposes at least 50% of patients to unnecessary chemotherapy and its morbidity and mortality. And we know that chemotherapy is not a risk-free modality either. There is a number of long-term complications which have been associated with this type of chemotherapy in the last 10 years since we have all those long-term survivors and are able to study those long-term toxicity. That includes renal toxicity, fertility issues, secondary leukemias. The risk is small, but it is there. Ototoxicity, cardiovascular morbidity, and others. We know that these long-term side effects are probably dose-dependent, and the long-term toxicity after 1 or 2 cycles of BEP are likely small, but we don't really have these data yet, and we can't really tell how potentially toxic these regimens are in the adjuvant setting. That brings us to the third option, and that is active surveillance, which has increasingly been studied over the last 10 years. And as you can see here, virtually all series from experienced centers have reported outcomes in survival rates in the range of 98 to 100%, clearly stating that active surveillance is feasible, it's safe, and results in excellent outcomes. Our own results in BC, and these are shown here, we treated about 160 patients between 1999 and 2007 with stage 1 non-seminoma, and virtually all of these patients went on active surveillance. We only have about 10 patients who received adjuvant chemotherapy. And our own results shown here, we had 34 relapses in this group of patients. The median time to relapse was about 4 months. The latest relapse was 14 months, illustrating that these relapses usually happen very quickly. Most importantly, all these patients relapse with good prognosis disease, which means they have the highest chance of cure. We treated them with standard chemotherapy. The majority of these patients usually attains complete remission. Only 4 patients required a second treatment modality, an RPLND, for post-chemotherapy residual disease, and only 2 patients relapsed after first-line therapy, resulting in a disease-specific and overall survival of 100% after a median follow-up of about 5 months. So when we attempt a risk-benefit analysis, we can say that we required 102 cycles of chemotherapy. If we had given all patients adjuvant chemotherapy, we would have needed 318 cycles. So we have avoided 216 cycles of chemotherapy. If we only treat high-risk patients with adjuvant chemotherapy, so only those 50%, only those 30% of patients who have lymphovascular invasion, we would probably have needed about 72 cycles of chemo. We would have needed 96 cycles of chemotherapy if all of them had received adjuvant chemotherapy, while if we look at only those patients who relapsed, we only used 72 cycles. So we have avoided a significant number of chemotherapy for our total patient population, which is exactly what we want in order to avoid long-term toxicity in these young patients. And these strategies are now reflected in most guidelines around the world. The Canadian consensus from last year stated that surveillance should be considered as the management option of choice for all patients with stage 1 non-seminoma, independent of risk status. The European consensus in 2008, which will be updated in about a week, where we meet in Germany again to update that consensus, and the European Urology Association consensus, which was just recently updated, states that patients with low-risk disease, so without lymphovascular invasion, should go on active surveillance. Patients with high-risk disease should either receive adjuvant chemotherapy with 2 cycles of BEP, but surveillance is certainly a possible alternative strategy. The only guidelines which are a little bit outdated in that regard are the NCCN guidelines. They do state that active surveillance or primary RPLND should be instituted for low-risk disease. And for high-risk disease, these guidelines still recommend primary RPLND as a valid option, or adjuvant chemotherapy or active surveillance. So in conclusion, I think, and this is something which has been done in BC for the last 10-15 years, we have not really done any systematic primary RPLNDs anymore for stage 1 non-seminoma. Adjuvant chemotherapy as well as active surveillance are treatment options. We in BC think that active surveillance should be the preferred strategy independent of vascular invasion status because it's highly effective with excellent outcomes. It only exposes those patients to active treatment and toxicity who really need it. The compliance issue is debatable, but obviously the compliance is good enough to have a 100% survival outcome and to have all patients relapse with good prognosis disease. The surveillance schedule, how exactly we should follow these patients with how many CT scans, number and timing of these imaging studies, that is up for debate and is currently intensively researched. But I think we have made a lot of progress there as well, because we have been able to cut back on the number of CT scans we need quite significantly. A similar paradigms are true for seminoma, even more because seminoma is a relatively indolent disease. Seminomas can grow for a very long time locally before they metastasize, and even more patients with seminoma present as clinical stage 1, up to 85% present with clinical stage 1 disease. And a recurrence after orchiectomy is actually quite uncommon. If you look at the current series of stage 1 seminoma, the overall recurrence rate in this group of patients is about 15%. We know that death from any stage seminoma is actually quite rare. Chemotherapy is highly curative, radiation is highly curative. And in an MRC series of almost 1,500 patients, they only had, with 1,500 stage 1 patients, they only had 1 death from seminoma. So even more here, quality of life is the driver of decisions in early stage disease. We have, for the very same reasons, any adjuvant therapy is associated with toxicity, and active surveillance can deliver excellent outcomes. So similar here, we have a number of different treatment options which we can discuss with our patients. Adjuvant radiation of the periodic lymph nodes has been the option which has been around the longest. Adjuvant chemotherapy with 1 to 2 cycles of carboplatin is an alternative option, and active surveillance. Again, similar to stage 1 non-seminoma, the outcomes are almost universal cure, and that is what we should aim for. Unfortunately, in contrast to non-seminoma, we have still not been able to identify a good risk classification which would predict which patients are at risk for recurrence and which patients are not. This classification shown here is the classification which was published by the Toronto group in 2002 and used tumor size and rete-testis involvement in the primary tumor as criteria to identify risk groups. And as you can see here, the predictive ability ranges from about a 12% recurrence for patients with small tumors and no rete-testis involvement to about 30% for those patients who have large tumors and rete-testis involvement. Unfortunately, this classification has never been externally validated, and even if it was true, it still discriminates quite poorly, because 70% of patients in the so-called high-risk group would still be cured with orchiectomy alone and overtreated if they received any adjuvant therapy. And in fact, when the group attempted a validation analysis, and this is an analysis where we submitted our BC patients as well to and tried to verify that classification, that analysis failed, and we could not verify that these risk factors really predict for relapse. So for the time being, we argue that this prognostic model should not be used. The risk of recurrence for stage 1 seminoma is about 15 to 20%, and we are not able to further discriminate patients with a higher risk or a lower risk. That, of course, makes the application of adjuvant therapy quite difficult, because we overtreat a significant number of patients. Adjuvant radiation has been around the longest. It reliably cures patients. A relapse from adjuvant radiation is quite rare, as you can see here. Almost all patients survive. The risk of recurrence is about 3 to 5%, and almost all of these recurrences happen outside of the retroperitoneum. But of course, about 80 to 85% of these patients are unnecessarily exposed to the risk of radiation. And we know now that the risk of radiation is actually quite high. There are 2 major toxicities which make therapeutic radiation quite unattractive. And that is, number 1, the cardiac toxicity, which has even been shown to be increased for patients who receive periodic radiation alone without mediastinal radiation. And then the issue of secondary malignancies, which has been shown to be a major issue for these patients. And keep in mind, these are young patients. We don't talk about 70-year-old patients where the potential long-term toxicity 30 years from now doesn't really play a role. These are 20 to 40-year-old patients who certainly have a normal life expectancy after they had their testicular cancer, and the majority of them will actually be exposed to these potential long-term complications. And it has been shown that these toxicities translate into a clinically relevant number of patients and has significantly impacted the way we treat this malignancy today. One of the first steps was to see whether we can find alternative treatment options to avoid radiation, and that's where carboplatin came in. Carboplatin is a chemotherapy agent. I always call it the little sister of cisplatin. We know that carboplatin is inferior to cisplatin in testicular cancer, but it has been shown that it's quite highly active in seminoma. And the thought behind doing these studies was that maybe we can get away with carboplatin, which is much better tolerated than cisplatin. And this is a study which was done by the MRC and compared adjuvant radiation with adjuvant carboplatin. And it showed that carboplatin was non-inferior. This was not an equivalent study and not a superiority study. It was a non-inferiority study. And it shows that carboplatin is non-inferior with a range, in a range of about 3 to 4%. So carboplatin consistently decreases the risk of recurrence. It does not completely eliminate the risk of recurrence. Again, it exposes 80 to 85% of patients unnecessarily to treatment. It still requires follow-up, and the long-term outcome and toxicity of this treatment option, albeit thought to be small, is unclear, and we don't know what long-term complications there are with carboplatin because carboplatin has so far not been used in a curatively treated patient population, and there are not many long-term survivors out there who have received carboplatin. And that leads us to the third treatment option, surveillance, which has been studied for the last 10, 20 years, and virtually all of the large series report a very consistent relapse rate in the range of 15 to 20%, and a disease-specific survival in the range of about 100%, clearly showing that active surveillance is feasible for these patients, has excellent outcomes. In BC, our own results, again, no, yes. Our own results, again, show that we had about 313 patients between 1999 and 2007. Median age was older. It's about 37 years. No.
Could you comment on the cost of the surveillance protocols and the CTs?
Well, the cost of this, well, it's relative because you still have to follow patients even if you treat them. So if you, and that applies in particular to carboplatin for stage 1 seminoma because the bulk of the recurrences happens actually in the retroperitoneum, in contrast to radiation where you can basically cut out the CT scans for the retroperitoneum. But you can't do that with carboplatin. Now, it depends really on which guideline you look at. And just to give you an extreme example, if you look at the NCCN guidelines for stage 1 seminoma surveillance, they recommend, and I'm not kidding, 23 CT scans over the period of 10 years. We do about 7. So it really depends on what you do. And we have also made progress in terms of what we do for follow-up. There has been now studies showing that low-dose CT scan, which is a CT scan technique which uses about 50% of the radiation of a regular CT scan, is as good in finding recurrences as a normal CT scan. We use MRI more. At the Cancer Agency, we are increasingly using MRI as a non-radiation associated technique. So it has been quite significantly refined And really the most important time period for these patients is the first 2 years for non-seminoma and probably the first 3 for seminoma, because a higher proportion of these patients can relapse a bit later due to the less aggressive biology of the disease.
Is the surveillance for stage 1 non-seminoma less intense if you've given them 2 cycles of BEP?
Yes.
So,
Yes, because the risk of recurrence after 2 cycles of BEP is in the range of about 2%.
so the cost differential is significant?
Well, I think if you factor in the treatment costs for 2 cycles of BEP, the fact that you overtreat at least 50%, if you only treat the high-risk population, and the potential long-term toxicity, I think the treatment option is probably much more expensive than the follow-up.
I'm just not sure which slide you were on.
No worries. So these are our results. We had 47 relapses, around 20%, exactly in the predicted range, with a median time to relapse of about 14 months. That you can see for non-seminoma, it was 4 months. All patients relapsed with good prognosis disease. The treatment and relapse was predominantly chemotherapy. About 32% of patients received therapeutic radiation. But we had a disease-specific survival of 100%, clearly documenting the good outcomes for this. Compliance is always cited a big argument against active surveillance, and I would just like to make a couple of comments. Compliance is required for any strategy. Regardless of what you do, a patient has to be followed, and there is always a risk of recurrence. There is virtually really no evidence that lack of compliance actually changes something, in particular in stage 1 seminoma. Regardless which study you look at and what degree of compliance they had, the outcomes are quite predictable and uniformly good across these modern studies. So I think it is very difficult to identify a patient who will be compliant and who will not compliant. There's a couple of factors which predict good compliance. If a patient is married, that usually predicts for very good compliance because you can always phone their wives and they give them help. But usually there are not good factors which predict which patient is compliant and which not. So we usually don't use that argument much unless the patient clearly tells you that he's going to move out of the country and into a third world country where he doesn't have any access to healthcare. But for patients who live in BC, I think they all have easy access to healthcare, and the compliance is usually quite good. So I've shown you that with surveillance, the recurrence rates are in the range of 15 to 20%. They have a very predictable recurrence pattern, and virtually all of these patients relapse with retroperitoneal lymph node disease. We have very effective salvage treatment, which allows us to watch these patients and use the event recurrence as our trigger to treat. And by doing that, we can avoid treatment-related toxicity and treatment for the vast majority of these patients with a very equivalent outcome as if we had treated them. And again, that is now reflected in the various guidelines. The Canadian and the European consensus guidelines are very similar. Surveillance should be the management option of choice for stage 1 seminoma. In fact, the European Urology Association guidelines, which were just recently updated, are the first ones who explicitly state that you should avoid adjuvant radiation in that stage of disease due to the potential long-term complications. And it's really the NCCN guidelines which stand out again. Although they were recently updated and now state that surveillance could be an option, they still have adjuvant radiation there. And the sad truth is that there was a study last year published in the JCO which did a survey amongst US radiation oncologists about their treatment preference for stage 1 seminoma. And about 60 to 70% of these radiation oncologists routinely recommend adjuvant radiation as their first choice. And the most common reason why they recommend that is because they think patients die when they relapse. So I think there's a lot of education to be done about that. So,
because that's how they earn their revenue.
pardon me?
That's how they get their revenue.
Well, you said that.
Was that a choice on the?
Pardon me?
Was that a choice on the question?
I don't know. It probably is a reason, but it's a very sad one. So we think that adjuvant radiation should be avoided for these patients with clinical stage 1 seminoma, with very few exceptions. Adjuvant chemotherapy can be given for a patient who is absolutely unwilling to undergo active surveillance. But here in BC, active surveillance is the preferred strategy for all patients. We don't really have any reliable marker to predict relapse. Active surveillance is highly effective and only exposes those patients to toxicity who really need it. Oops, there you go. So in conclusion, for stage 1 disease, these patients are highly curable. Minimizing treatment-related toxicity while maintaining efficacy is the primary objective, and I think we have made a lot of progress there. We have different treatment strategies which can effectively manage these patients, but with very different total burdens of therapy. We need to explain these options to our patients, which sometimes can be a bit time-consuming, but for the very vast majority of patients, active surveillance will be and is the standard of care in this disease. Now, for stage 2 disease, when patients have relapsed or progressed with retroperitoneal lymph nodes, the situation is slightly different. And this shows you the treatment paradigm for metastatic non-seminoma patients. It is actually fairly similar for seminoma, but we will talk about the differences in a minute. So we usually do an orchiectomy, and then we start patients on chemotherapy depending on the risk status, either 3 or 4 cycles of BEP. If the patients have no residual tumor, we watch these patients, and if the patients do have residual lesions, then we usually recommend secondary resection because of the risk of residual vital carcinoma and even more the risk for residual teratoma. Now, for stage 2 disease, historically, there have been 3 different approaches. One was primary RPLND followed by adjuvant chemotherapy. One approach was primary RPLND without any further treatment, and then primary chemotherapy with resection of residual disease. And over the last 10 years, virtually all guidelines agree now that the preferred approach should be primary chemotherapy followed by resection of residual disease. A big point of debate are usually stage 2 patients, stage 2A patients, in particular if they are marker negative. If they are marker positive, then the decision to go for chemotherapy is usually quite easy. But if they are marker negative, then we have a problem, because it has been clearly shown that up to 50% of these patients actually are not metastatic, but have enlarged or suspicious lymph nodes for other reasons, as you can see here from a series from the MSKCC. And it can be very difficult to differentiate between benign nodes and malignant nodes, and even PET scan cannot reliably do that. So what our strategy in this disease is usually that we do a confirmatory CT scan after 2 to 4 months, and if these lymph nodes clearly progress and or if the marker turn negative, then we usually recommend chemotherapy. But most often we don't immediately treat these patients with chemotherapy. An alternative option, in particular if the patient has had a lot of teratoma in his primary tumor, would be to send these patients for a primary RPLND to see whether or not there is tumor in these patients. But again, about 50% of these patients would have an RPLND without actually having disease. And that just shows you one of those examples. As you can see here, the patient has quite 3 small lymph nodes here in the retroperitoneum, and we were very tempted to treat that patient with chemotherapy, but we didn't, and we started to follow the patient, and over the next years, the patient did not have any change in these lymph nodes, whether at 3, 6, 21 months or 44 months, and the patient eventually was diagnosed with inflammatory bowel disease. That is certainly an extreme example, but it shows you that you can be tricked with these lymph nodes, and it's usually good to have a confirmation and some criteria that this is really disease and not something else. We treat these patients according to risk groups with chemotherapy. These metastatic patients, if they are good prognosis, they get 3 cycles. If they are intermediate or poor, they get 4 cycles. A relapse with intermediate or poor prognosis after a period of surveillance for stage 1 disease is extremely rare, and almost all of these patients relapse with good prognosis disease. A matter of debate over the last years has been, what are we doing with these retroperitoneal lesions? Virtually all guidelines agree that for non-seminoma patients, a residual lesion of more than 1 centimeter should be resected. That's standard in all guidelines. Where the guidelines disagree is, what should we do with lesions which are less than a centimeter? A patient has a good response, the retroperitoneal nodal mass shrinks to less than a centimeter, which we would consider a clinical complete remission, or disappears entirely. Should we still offer these patients an RPLND, yes or no? And a series from Indiana and then our own series here from UBC combined with the Oregon data, showed that we can actually watch these patients quite safely if they attain a clinical complete remission. That is certainly in contrast to other institutions. MSKCC, for example, still recommends a RPLND even in patients who have a CT scan clinical complete remission without any nodes in the retroperitoneum, because they think that there is still a risk that teratoma can be there and potentially cause a late recurrence down the road. That has not been shown in our series, so that remains controversial, but we have been following this strategy now for about 10 years, 10, 15 years, and it has turned out to be quite safe. So for non-seminoma, the strategy would be to resect all residual disease of more than 1 centimeter. If it's less than 1 centimeter or no residual tumor, we would just watch these patients. And I mentioned that there's absolutely no indication for a PET scan in assessing these residual lesions. I see that over and over that physicians request PET scans for residual lesions in non-seminoma. The bottom line is, if you have a residual lesion which is PET positive, the next step would be to resect it. If you have a residual lesion which is PET negative, the next step would be to resect it. So a PET scan really doesn't help you. It cannot differentiate between necrosis and teratoma, and that's really what you want to know. So a PET scan is not helpful in that situation. For metastatic seminoma, the strategy is initially the same. We do an orchiectomy, we treat them with chemotherapy, and if they have no residual tumor, we observe. If they have residual tumor, then we can either watch or we can actually use a PET scan, and I will show you that data in a second. Chemotherapy for metastatic seminoma is highly effective, as you can see here. Cisplatin combination chemotherapy cures by the very vast majority of patients, and cure rates for stage 2 seminoma are in the range of about 98 to 99%. And death from metastatic seminoma is extremely rare. For stage 2 seminoma, we have a number of treatment options. We can either treat them with radiation for stage 2A and stage 2B. That is still an accepted treatment option, or we can treat them with combination chemotherapy. All of these options result in the same outcome, and we usually consider potential long-term complications, pre-existing conditions, and patients' preferences. Primary chemotherapy has been shown to be very effective, equally effective to radiation, as you can see here. And in BC, over the last 10 years, due to the potential long-term complications of radiation, radiation for stage 2 seminoma has basically disappeared. The radiation oncologists are very hesitant to offer radiation to these highly curable patients because of the potential long-term complications. And we have very excellent outcomes. Over the last 10 years, we have not lost any patient with seminoma, regardless of metastatic or non-metastatic, and we have a disease-specific survival of about 100%. So what do we do with these residual lesions, which are exceedingly common in patients with stage 2 seminoma? About 30 to 80% of patients have them, depending on what series you look at. If a patient has a lesion of more than 3 centimeters, then about 10 to 30% of these patients will have residual disease. If the lesion is less than 3 centimeter, viable tumor is rare, less than 10%. The problem with residual disease of seminoma, and I don't have to tell you that, is that the resection is often quite difficult, and much more so than in non-seminoma. The good thing is that we don't have a risk of teratoma. So what can we do? This is a patient who had this large lymph node in his pelvis, as you can see here, and we treated that patient with chemotherapy, and the patient had a very good response. But by July, as you can see here, in June, at the end of the chemotherapy, the patient had a very good response, but in July there was a suspicion that the tumor was progressing. We did a PET scan on this patient, and the tumor did light up quite significantly, as you can see here. And the question was what to do with these patients, with this patient now. Should we immediately send the patient to salvage chemotherapy, or should we try to resect that? And that is always a difficult question, because if the patient has been shown to be cisplatin refractory, these are patients who usually do quite poorly with chemotherapy, and we usually prefer a different treatment option. So in this patient, the decision was to proceed with resection, and indeed there was vital seminoma of about 4 centimeters, and unfortunately the resection margin was positive. So the question was what to do with this patient next, and we decided to treat these patients with high-dose chemotherapy as a salvage option. And the patient underwent tandem high-dose chemotherapy and had no further relapse, and I think it's safe to say that this patient is cured. So for the residual lesions in this setting, we can use PET scan in contrast to non-seminoma, because there is no risk of teratoma in these patients. And a PET scan done in a timely fashion post-chemotherapy, so about 8 to 9 weeks after the completion of chemotherapy, has been shown to be a good discriminative tool for patients with residual lesions of more than 3 centimeters. If these lesions are PET positive, then it's highly likely that they have residual disease. If these lesions are PET negative, then it's highly unlikely that these patients will recur. And this is really the only standard indication for PET in metastatic germ cell tumors to date. So again, in summary, that shows you the treatment paradigm for these patients. If they have no residual lesions, we watch. If they have residual disease, then we either watch or do a PET scan in order to find out more about this residual lesion. So in conclusion, patients with clinical stage 2 disease similar to stage 1 are reliably cured. We have achieved to minimize toxicity while maintaining efficacy, and the cure rates for metastatic seminoma these days are excellent, and almost all patients are cured. We again have different treatment strategies, and we need to talk to our patients about these in order to make the right decision for the individual patient. Primary chemotherapy is really moving into the first spot for patients with metastatic disease, and radiation is increasingly not longer done. It is said that cooking is an art and baking is a science. The management of testicular cancer is like baking. If it's done precisely, if it is done according to the guidelines, it provides excellent outcomes, and these outcomes are actually predictable. And I think this is something which we have managed in BC, thanks to what I think is the excellent cooperation between the different involved disciplines, the urologists, the radiation oncologists, and the medical oncologists. We have implemented very high-level treatment on a broad basis, and that certainly differentiates us from a lot of countries, including the US, as well as a lot of countries in Europe, and that results in these absolute fantastic outcomes, which we just calculated. These are the outcomes for any type testicular cancer in BC over the last years, and I don't think that I really have to comment these outcomes. They are on the top around the world, and almost all of our patients are cured. So in conclusion, I think the discovery and development in the management of this disease has been remarkable. We have turned a disease from almost universal death to universal cure. We have extremely effective management tools, and I think the most current pressing clinical challenge is the consistent delivery of these treatment strategies over broad geographies. It's a rare disease. It requires expert input. It has been clearly shown that patients treated at expert centers do better than patients who are not treated in expert centers, and that applies in particular to metastatic patients. And that is something which I think we have managed in BC, and that is reflected in these excellent outcomes. Thank you very much.